Good evening, my dear students. I hope all of you are doing well. I am Dr. Salah Shaheen, Professor of General Surgery, Qasr Hospital, Cairo University, Egypt. Welcome back to my channel, General Surgery Notes for Dental Students. Tonight's video is about thyroid disorders. A goiter is defined as an enlargement of the thyroid gland, whatever the cause. May be simple goiter, may be toxic, neoplastic, or may be caused by thyroiditis. These are the differential diagnoses of an enlargement of the thyroid gland. By the way, any part of this video which is marked by flashing red button named advanced is not required in details. Only it is for understanding this part of the video. If you feel that part of the video is not clear, you may pause the video and rewind it, and you may repeat many times until you understand the point. Let's start. Enjoy the video.
Thyroid gland is an endocrine gland, which is defined as an organ that makes hormones, which are released into the blood and travel to the tissues and organs all over the body. The thyroid gland produces thyroid hormones, which are secreted by the follicular cells, and calcitonin hormone that is secreted by the parafollicular cells. Thyroid hormones are triiodothyronine or T3 and tetraiodothyronine or T4, which is also called thyroxine hormone. Surgical anatomy. Thyroid gland is butterfly shaped. It is formed of two lobes, each is the size of a thumb, connected by an isthmus. It is located in both muscular triangles of the neck. It is wrapped around the trachea and the esophagus, just below the thyroid cartilage. The thyroid gland is enclosed between the two layers of the pretracheal fascia. The latter is attached to the thyroid cartilage and hyoid bone. This explains why the thyroid gland moves up and down with swallowing. Thyroid gland has a rich blood supply. The nerves related to the thyroid gland are superior laryngeal nerve and the recurrent laryngeal nerve. Both are branches of the vagus nerve. The back of the thyroid gland is related to the four parathyroid glands. Surgical physiology. Thyroid hormone synthesis is as follows. Thyroglobulin is sensitized by the follicular cells and then is secreted in the lumen of the follicles to be stored in the colloid. Iodide ions are pumped into the follicular cells with the sodium ions and then pumped to the colloid in exchange with chloride ions. In the colloid, iodide ions are oxidized to iodine elements. This is followed by many steps under enzymatic control, including iodinization, coupling, and this ends by formation of thyroid hormones, namely triiodothyronine or T3 and tetraiodothyronine or T4 or thyroxine. Both T3 and T4 remain bound to the thyroglobulin and stored in the colloid until they are needed. When the gland starts to secrete thyroid hormones, thyroglobulin with the attached hormones enter the follicular cells by a process of endocytosis. Inside the cells, thyroid hormones are cleaved out from the thyroglobulin and release into the bloodstream. Mostly thyroid hormones in the bloodstream are bound with the plasma proteins with little fraction as free form, which is biologically active. Control of thyroid hormone secretion. The hypothalamus secretes thyrotropin-releasing hormone, TRH. The hormone passes through a hypophyseal portal system, which is a capillary network between the hypothalamus and the anterior pituitary. Then, the anterior pituitary releases thyroid-stimulating hormone, TSH, which passes through blood to the thyroid gland. Then TSH stimulates the thyroid gland to secrete T3 and T4. Once these hormones are released into the bloodstream, they bind mostly to the circulating plasma proteins with little amount unbound as a free form. The thyroid hormones reach each cell in the body, and once inside the cells, T4 is mostly converted to T3 to exert its action. To work properly, the thyroid hormones have to be within a normal range. With low-level thyroid hormone, a negative feedback mechanism works, where the hypothalamus and the anterior pituitary are stimulated to increase the secretion of TRH and TSH, and then the circle continues till thyroid hormones return to the normal level. This is the negative feedback mechanism. Goiter is defined as an enlargement of the thyroid gland. Goiters may be simple, which is non-inflammatory, non-toxic, and non-neoplastic enlargement of the thyroid gland. The function is not disturbed. Examples are simple physiological goiter, colloid goiter, and simple nodular goiter or SNG. Next form is toxic goiter, where there is hyperthyroidism associating the goiter. It is better named thyrotoxicosis. Examples are diffuse toxic goiter, also called primary toxic goiter or Graves' disease. This represents about 75% of all toxic goiters. Next is toxic nodular or secondary toxic nodular goiter, which is also called Plummer's disease. That represents about 15%. The third important type is toxic nodule that represent about only 5%. In addition, there are other rare types like Jod basido, thyrotoxicosis factatia, etc. The third form of goiter is thyroiditis, which is an inflammation of the thyroid gland. The inflammation is mostly autoimmune in origin, like the Hashimoto's disease and the Dürr-Van disease. Very rarely thyroiditis is bacterial in origin. The last form of goiter is neoplastic, which is a tumor affecting the thyroid gland that may be benign or malignant. Let us start by simple goiter, which is defined as non-inflammatory, non-neoplastic enlargement of the thyroid gland without any disturbances of the function. During the periods of increased physiological demand for thyroid hormones, like at puberty, during menstruation, or lactation and pregnancy, there is increased TSH production by the pituitary gland. This TSH stimulates the thyroid gland to produce and release thyroxine hormones. All the follicles are active. They are lined by hypertrophied cells that become also hyperplastic. In other words, there is diffuse hyperplasia of the thyroid gland. and this is called simple physiological goiter. It is the commonest cause of thyroid enlargement, occurring commonly in females. Sporadic cases are seen at time of stresses, but may appear early during childhood in endemic areas like oases in Egypt. Remember that normal thyroid gland is impalpable. In simple physiological goiter, the patient clinically presents with a diffuse, mild thyroid swelling, which is butterfly or horseshoe in shape. This diffuse enlargement of the thyroid is symmetrical, smooth, and soft in consistency. After subsidence of the stress, the gland returns to its normal size, and the follicles involute to the normal shape. This involution means the process is reversible. The period of stresses are repeated, so the course of the condition is typically intermittent. Being a physiological condition, there is neither need for medications nor for investigations, and only assurance of the patient is the only required measure. Now let us shift to the simple colloid goiter. Sometimes hyperinvolution of the diffuse hyperplastic goiter may occur, especially after intake of a large dose of iodine. It is considered as a late stage of physiological goiter. The follicles are large, lined by flat epithelium, and filled with colloid. Clinically, the gland is larger, more fur with a lobulated surface. Point of interest in contrast to simple physiological goiter, which is reversible, this process is not reversible. Thyroidectomy may be indicated if the gland is large in size for cosmetic purpose. Now it is time to discuss simple nodular goiter, SNG, or it is also called multinodular goiter, MNG. Causes include environmental factor due to iodine deficiency in water and food, as occurs in mountainous ranges and lowland areas. In Egypt, endemic areas are oases. Iodine deficiency may be absolute or relative at times of stress. Now, the use of iodized table salt has led to successful reduction of the incidence of endemic goiters. Number two, familial factor due to dyshomogenesis or enzyme deficiency. This is responsible for many sporadic cases. Patients usually develop goiter at a young age, and sometimes several members of the family are affected. Number three, goitrogens. Cabbage that contains cythionate, also drugs like para-aminosalicylic acid and antithyroid drugs. Pathogenesis. Relative or absolute thyroid hormones deficiency leads to resistant TSH elevation that produces hypertrophy and hyperplasia of all the follicles of the thyroid gland. This is the stage of diffuse hyperplasia or simple physiological goiter. If iodine requirements are satisfied, the follicles undergo involution or even hyperinvolution, and this is the stage of colloid goiter. Later, as a result of repeated fluctuating stimulation, a mixed pattern develops with areas of active lobules and areas of inactive lobules. The active lobules become more vascular and hyperplastic until hemorrhage occurs, causing central necrosis, leaving a narrow rim of active follicles. Then necrotic lobules coalesce to form nodules. The nodules are enclosed by delicate connective tissue. Continual repetition of this process results in different nodules with heterogeneity in structure. In a single lobule, all the follicles behave similarly. Now, a nodular goiter is evident. Most of the nodules in a nodular goiter are inactive, while it is the internodular tissue that shows active follicles. Clinical features. Females are affected more than males. Goiter is a disease of the middle age, but can occur at a younger age in endemic areas. Patients are in euthyroid states to say no hyper and no hypofunction of the thyroid gland, commonly present by asymptomatic neck mass. The main complaint is cosmetic deformity. Thyroid gland enlargement is localized or diffuse asymmetrical, with a nodular surface. The goiter moves up and down with swallowing. Consistency is heterogeneous but almost firm, may be hard if calcified or cystic if degenerated. The carotid artery may be displaced backward if the gland is huge in size. Trachea may be displaced or pinked if compressed from one side. Complications of simple nodular goiter include tracheal obstruction caused by compression on either side, and the trachea is transferred to an anteroposterior slit. Trachea may be displaced to one side and will be kinked when there is marked unilateral enlargement of the thyroid gland. Next complication is calcification, and this is usually occur in long-standing goiter, and the gland will feel hard. Another complication is cyst degeneration. Hemorrhage may occur into a nodule or into a cyst, causing respiratory embarrassment. Nodular goiter may be complicated by secondary thyrotoxicosis in 30% of cases. It is usually the internodular tissue which become hyperfunctioning, but sometimes one of the nodules may be the hyperfunctioning tissue. Malignancy may occur in 3% of cases, and it will be usually follicular type. The last complication is retrosternal extension, causing mediastinal syndrome with superior vena cava obstruction. The investigations to confirm the clinical diagnosis of a simple nodular goiter are: number one, thyroid profile that includes T3, T4, and TSH. They are within a normal range. Number two, neck ultrasonography. Very diagnostic to show the nodules, differentiate cyst from a solid nodule, confirm or exclude the presence of cervical lymph node enlargement. Number three, indirect laryngoscopy, especially in patients with recurrent goiter to assess the mobility of the vocal cords. Lastly, fine needle aspiration cytology if a nodule is suspicious. No need to ask for thyroid scan. The treatment is surgery. Surgery is indicated for cosmetic reasons, liability to complications, if there is compression symptoms like dyspnea or dysphagia, there is retrosternal extension, and if there is any risk for malignant transformation. The surgery done ranges from lobectomy to total thyroidectomy.
Thank you for watching this video. I hope this video was simple, illustrative, and to the point. If you feel such like that, please give a big thumbs up and share it with your friends. Don't forget to hit the bell so you will be notified whenever I post a new video in this channel. Please subscribe to my channel, so this will help me to produce much more videos. Thank you again and good luck. See you in the next video.